right. I'd like to welcome everyone. My name is Horst von Rakum. I'm a professor of biomedical engineering at Case Western Reserve University, and it's my honor and privilege to introduce you to the Open BME seminar series. So if this is your first seminar, or if you've been to several of these, just want you to know that it's Open BME is a consortium of 7 different universities, 7 different top BME programs within the country that are working together to try to collectively expose their students to some of the top leaders in the biomedical engineering field. Today, Case Western Reserve University has the honor of hosting the speaker, and just want to use this slide to introduce upcoming speakers. So Case is hosting next week's speaker as well, Dr. Daniel Bassett from University of Pennsylvania. Anyway, one logistics event. So you may have noticed the chat is disabled, but we have a Q&A feature enabled in the bottom of your screen. So if you along the way have questions, feel free to start typing them into Q&A. If you want to keep track of other people's questions, you can upvote or downvote other people's questions, just like in Twitter or Reddit or whatever social media platform you like to use. At the end of the speaker's presentation, she'll have access to the questions and we'll be able to get to the questions. So if you like a question and want to vote it up, feel free to do so. All right, with that, I'm going to introduce Professor Andrew Rollins, a colleague in my department, and he'll introduce today's speaker. Professor Rollins.
Thank you, Horst, for that kind introduction. I'm honored to have the chance to introduce our speaker today. Adriana Velazquez earned her undergraduate degree in biomedical engineering from Universidad Iberoamericana in Mexico, and then her master's degree in clinical engineering from Case Western Reserve University. She's throughout her career served in many functions through the healthcare systems in Mexico and internationally, including biomedical engineering and clinical engineering positions. Then serving in the Ministry of Health in Mexico, internationally in the Pan American Health Organization and the World Health Organization, where she is currently a senior advisor and focal point for medical devices. I told her I think she needs a flashier title. She's really the boss of biomedical engineering at the World Health Organization. That may not be clear from her title. She's served in many professional and honorary positions. She served as the president of the Latin American Regional Council of Biomedical Engineering, president of the Mexican Society of Biomedical Engineers, chair of clinical engineering at the International Federation for Medical and Biomedical Engineering, and many other positions. Among her awards that have honored her include the First International Clinical Engineering Award, Distinguished Alumni Awards from her alma mater, Clinical Engineering Individual Award from the International Federation for Medical and Biological Imaging, Humanitarian Award from the Association for the Advancement of Medical Instrumentation, and so on. In short, our speaker, Adriana, is a very distinguished professional and alumna of our department here in biomedical engineering at Case. We're very proud of our association with her. On a personal note, I think the way I met Adriana is a little bit telling of her stature. I met her at a biomedical engineering regional conference in East Africa hosted by Makerere University in Uganda. And I was there to give a presentation about work in collaboration with Makerere University's biomedical engineering department. But she was the keynote, and I I felt like I was at a rock concert when she walked in the room. Everybody knew her and everybody was so excited to see her. So many in the room knew her because she had personally helped them. And we in the US, have our love-hate relationship with the FDA, but imagine if you were working in a country or region that had no functioning regulatory system. Who would you turn to? Well, for many people in that position in the world, they turn to Adriana, and she helps them and their programs and their ministries and their governments. So we're very honored to have her time, and I won't take any more of it. So please help me welcome Adriana Velazquez. Thank you.
Thank you. I don't know what happened. Thank you very much, Andrew, and thank you all the organizers for inviting me to give this talk today. I'm very proud to be WHO, but I'm also very proud to be alumni from Case Western Reserve University. I'm very glad to be with all of you today. So without any further ado, I will start my presentation. So I'll share my screen. Just make sure everything works well. Is that working?
Yes, looks good.
Okay, thank you very much. Okay, so the title of my presentation today is, as the world gets smaller, how can we expand the biomedical engineering impact to global health? So I have the agenda for you, and it's the world really is getting smaller. Where can we as biomedical engineers have impact? Local, regional, and global health. Which are the challenges that we have? Well, many. We have infectious diseases, as the world faces today, but we still have non-communicable diseases, cancer, diabetes, cardiovascular diseases, they're there. And also all the diseases related to the health, life course conditions, pregnancy, reproductive health, maternal, newborn, child, and now aging. Of course, the medical technologies are there to protect us, to prevent diseases, to diagnose diseases, to treat diseases, to monitor, rehabilitate, and palliate. So we have a broad spectrum. And the areas of work are many. So it is on the innovation, regulation, selection, procurement, supply, training, and use of medical devices. That would be the topic of my talk, but I just put some nice images here to remind me of the time that I was at Case Western Reserve University. Then, as Andrew, and thank you for the introduction, I was in Mexico in private and public hospitals in the Ministry of Health in Cenetec, and I'm really glad that Cenetec still is there. In the government of Mexico. And then this is a picture I took just 2 weeks ago that we launched the third essential in vitro diagnostic list in WHO. So let's go a little bit backwards. We are in 2015 and we imagine the United Nations get together and they say we need to have sustainable development goals. We need to be reached, they need to be reached by 2030. So there's one that is called Good Health and Well-being, which, by the way, it is an EKG. It simulates an EKG. So our medical devices are there and the EKG is there. And then, of course, health has relation with many others. So, of course, it's related to industry, innovation, and infrastructure, just below it. And it could also, if we have good health, it will reduce inequalities, will increase for example, we have solutions about affordable and clean energy for hospitals, etc. So these are the sustainable development goals, and the idea is to reach them in 2030. Later, 2017, 2018, we had a new Director General coming to WHO, Dr. Tedros, and then from Ethiopia. And we started developing in WHO, along with the member states, the 3 billion target. So it is universal health coverage to get everybody covered for health. They cover 1 more billion people from health emergencies and 1 more billion people of health and well-being. Those were the goals back then. In that time, and that continues, but I'll just go back and forth in time a little bit, hypertension. Hypertension is a huge global challenge that we have. So how are we going to target it? It so happens that 1.1 billion people have hypertension, but 1 out of 5 do not know they have it. So this is really important. And of course, the blood pressure measurement machine, somebody will say it is a very easy device. It should be available everywhere. Well, no, it is not available everywhere. And it is in some countries is still on using mercury, and mercury should be banned out of healthcare services. Actually, it's very contaminated. So we developed technical specifications for blood pressure measurement devices. And now that was a year ago, we launched the book and now it is available. So we're giving some guidance to the biggest problems. Then we have another one, huge challenge, 5 billion people. Yes, you heard correctly. 5 billion people lack access to safe and affordable surgery. And this was a statement by the Lancet Commission on Global Surgery. So yeah, surgery is there, but people suffer or they have problems either after or caught an infection, or it was not safe enough, or it was not affordable. We have a number 1 killer of children for less than 5 years old. It's the pneumonia, and pneumonia is still there. So what can we do to face pneumonia? Well, first of all, we need in vitro diagnostics to diagnose if it is bacterial or viral pneumonia. We need oxygen support systems. And in 2019, along with UNICEF, we developed the technical specifications for oxygen therapy devices. And the idea was really to increase the availability of oxygen as an essential medicine in the world. So we're continue to work on different aspects. Another one in 2019 that was major was patient safety. So many, 4 out of 10 patients are harmed in primary and ambulatory care settings. So there was a call from Dr. Tedros and for the member states saying we really need to ensure that safe care is it's a major challenge. And we need to ensure that with innovation, we make sure that the patient safety is number 1. It's really concerned. In December 2019, I was with some colleagues in the US in a meeting trying to define innovative PPEs for Ebola protection. And the pictures that are here is because we were in that meeting trying to define what would be the suits for Ebola. All this was happening in December 2019, and then the end of December, all of a sudden, COVID came. Everything changed. We still have the non-communicable diseases, we still have the infectious diseases, we still have lack of oxygen, we still have challenges with PPEs, and then Ebola came to our lives. So why is the world small? Because due to our interconnected small world, infection has spread. Now we have 2.5 million lives lost. And this is the map in the right hand with orange. And then we have 111 million cases of COVID. This is a major issue. How are we going to face it? So just last year, we dedicated to develop technical specifications for PPEs for COVID to protect healthcare workers. So just so that you have an idea with the specifications that we did, and that is the slide on the left hand, WHO purchased 476 million PPE products, and they were sent to 180 countries. UNDP, UNICEF, UNOPS, WHO, they all help support, and they all help sending PPE and personal protective equipment, and then showing them how it should be used or not, and how to ensure to save the lives of healthcare workers. And still, that's still a challenge. Okay, now we are here. We're biomedical engineers, And what is our role? Well, our role is to design, to evaluate, to regulate, and manage all medical devices to support local, regional, and global health. And as you can see from the photos that I took here, it's everywhere. There's an emergency room, there's the neonatal, there is a nice, a very advanced laboratory for cancer research. There is lack of oxygen, so we have to use these tanks. This is a hemodialysis unit in Yemen, glucometers, emergency care, and mobile clinics. So where are we going to work as a biomedical engineer? We need to help all those different settings, and we have to keep in our mind those settings. So, and what is the type of medical devices that I will be working on if I'm a biomedical engineer? Well, the range is really diverse. We have about, some people say 7,000, others 20,000, but we have more than 10,000 different types of medical devices. And that includes all medical equipment, all medical softwares, medical device, single-use medical devices, all the surgical instruments, implantable devices, all the in vitro diagnostics. And we as biomedical engineers need to know the physiology, the biochemistry, the medical instrumentation, the sensors, etc., to make sure that we know about them. So where are the biomedical engineers? Well, many people use, when I go to different countries, as Robert Andrew was saying, when we were in Uganda, many people tell me, oh no, Adriana, there are no biomedical engineers around the world. And then we demonstrated, yes, there are many biomedical engineers all around the world. We have all these countries have at least one biomedical engineering professional association by W2 regions. So we have 50% of them are in the Americas, but we also have in Africa, in the Eastern Mediterranean, in Europe, and even in Southeast Asia. And this is the map. This map was developed 2015, 2017, and now we are updating it. But as you can see, Southeast Asia, Europe, Latin America, and even some countries in sub-Saharan Africa, they all have some programs of biomedical engineering in the university. So this is expanding now. So we are trying to get more biomedical engineers all around the world. So the idea is if we take those biomedical engineers and then we ask them to design, manage, regulate medical devices, what we can do together is really impact local, regional, and global health. So now, how can we achieve that? Well, we are the ones that are responsible to ensure improved access of safe, good quality, affordable, available, accessible, acceptable medical devices. So on one side, we have some biomedical engineers that work in industry, they do research and development, that's one set, and that is with the red. Then we have others that do the selection. So those are the selection, like health technology assessment, trying to find the evidence of review of evidence of effectiveness of a device. Then we have others that work like exactly what Andrew was talking about, the FDA, like regulatory agencies to ensure that the devices are approved for marketing in countries, that they are safe and effective and good quality. And then we have all the area about health technology management. We need to define where are the needs, how to select it, how to procure it, how to do the training, and ensure that those devices are really meeting the needs of the society and the patients. So if we take these three colors that you see here, the pink, the green, and the blue, I'm sorry, it should be more bluish, we take, and this is a sequence. You regulate, you measure safety and performance, then you have the HTA, you measure clinical effectiveness, ethics, social issues, organizational, and then you go to the health technology management to ensure procurement, selection, training, and use is correct. In many countries, they have, we did a study on all these aspects, from innovation, selection, procurement, innovation, etc. And then we put everything together into the Global Atlas of Medical Devices. That is being updated as we speak for the new release. And what we have is, for example, in this map, you have which countries have a list of medical devices that is approved for procurement, reimbursement, or universal health coverage. which countries have a list, but it is just the recommendations, and which countries have no list. And then the list needs to be defined. So where do we need the biomedical engineers? Yeah, you need them in the hospitals, you need them in the industry, but you also need them some in regulatory agencies and also at governmental levels. So we need them to help the design and to make sure that those technologies should be matching the healthcare interventions that the country wants to give to its population. So we've been, since I'm in WHO, I've been 12 years. I think we have about 48 publications that we have done in that time. And I just selected some of them for you now. So the Global Atlas is really having the profile by country. The Green Book on, it's the model regulatory framework for medical devices to help countries exactly what Andrew was saying. If they don't know how to regulate devices, at least this is a step-by-step approach. And we have other books that were developed also by the Eastern Mediterranean region on a step-by-step approach. Then we have the human resources for medical devices. That was really to tell the world what is our role as biomedical engineers, what can we do, and how can we support countries, hospitals, industry, etc. And then we have the list that you have with yellow and salmon color. So it is the list of priority medical devices for reproductive, maternal, newborn, and childcare. So we went through every intervention that you have to do with a newborn baby, a pregnant mother, etc. And then we said, these are the interventions, clinical interventions that you have. These are the devices that you need. And where do you need it? Is it in an operating room? Is it in a clinic? Is it in a hospital? So we listed all of them. We listed the interventions, we listed the devices. And then we did exactly the same exercise for cancer management. And so these two books contain about 1,000 medical devices that should be used for all these interventions. And then the last one that we have here, it's the Compendium of Innovative Technologies. WHO has been making calls since 2011 to try to define what technologies are there that can be selected and published in these books so that then low and middle income countries or low resource settings can use these technologies. So they have to go through an assessment to say, this is a new technology that can be used where there's less energy or less stable electricity or lack of specialized human resources or very high temperatures or a lot of dust, or they need simple. So those are the technologies that you will find there. And then this is just a list so that you can see the numbers I was talking about. So for personal protective equipment, we have 11 elements. So we have to describe each of them. For the reproductive health, we have, I'm sorry, this slide got shifted, 484 plus all the surgical instruments. And then for the cancer book, we have 684 devices. And as you can see, you have the X-ray system, laboratory pathology, surgical instruments, glassware solutions, reagents, etc. And this is the framework. So when you use a device, you use it either to prevent, to diagnose or screen, to treat, or to do follow-up or monitoring for palliative care, and even for the end of life. And that is this arrow that you can see here. So we need devices in all of these areas. And then we need devices also on the vertical areas. This is what will be primary healthcare. So this is health posts, health centers, community centers, really the very, very basic vaccination, first clinical assessments, etc. And then we go to like a general hospital. And then we go to specialized hospitals. So in the specialized hospital, we have nuclear medicine, we have radiotherapy, we have systemic therapy, etc. But in these ones, we can have pathology, endoscopy. So for each of these units, all the devices that you need can be found in these books. And this took a long time to develop. And then once we developed with many experts, we went to Ghana, we sat down with the radiologists, with the pathologists, with the surgeon, with everything. And we said, do you have everything that you need in this list? Do we need to add something? Do we need to delete something? So it's a very long process, but at the end, it is like something to help them. This is just an image of one of the chapters, nuclear medicine and medical imaging. And we even got the permission to list what are the human resources that are needed to manage those devices. And so, well, we were working, and as I told you before, we were in 2015 doing the reproductive health, then the cancer care, and we were developing the cardiovascular stroke and diabetes book when COVID arrived. And then when COVID arrived, then we paused the cardiovascular stroke and diabetes book, and then we concentrated on the priority medical device list for COVID. This book was developed like in 3 months with an immense help from many, many organizations. And before, we used to take maybe like a year to do some technical specifications like the ones that I showed you about UNICEF and WHO. We took about a year and a half to do about maybe 25. Well, I can tell you that with the help of everybody, we achieved this book in record time, and we did about 100 specifications in less than 5 months. No? So then the publications get growing. So we have these publications that are for the process. And if you remember the colors, there were the greens for regulation, the purple for the health technology assessment, the blue ones for health technology management, like inventories, maintenance, donations, etc. And then the list of the priority medical devices was starting to grow. We also have a very important issue, and I just took this slide to remember that digital health or the software as medical device is really growing. It's now embedded in most of our medical devices, but we still keep some devices that are almost analog or mechanic, and some others that are digital, and then others that we need to include between the digital systems and the interface with the electronic health record, personalized medicine, artificial intelligence, computer-aided diagnostics, and then all that world now fall also into our responsibility. When COVID arrived, then we said, okay, we need to define what are those devices that are needed for testing, to treat patients, and to protect healthcare workers. And what is the quality and level of use that we need? So this slide represents the use of all those devices. And then we said, okay, for PPE, which ones we need and which are the levels of care that they need to use it? Where are the medical equipment? Where are the intensive care and the ventilators, the high flow nasal cannula, etc. And then also in vitro diagnostics and all the imaging diagnostics. We searched for the sources of oxygen that we could use. And as you all have seen in the news, oxygen is really, really needed all around the world. Then this is what I was telling you about. We took maybe for these other books about a year since conception to publication. And then all of a sudden in 5 months, we developed about 100 technical specifications. We even posted the interim guidance until we got the book ready. At the same time, simultaneously, there was a group working on screening and diagnostic steps and technical specifications for the chest imaging, use of chest imaging. So then we said, okay, you can screen with a, sorry, I just put on wrong, with the screen with a thermometer and a pulse oximeter. But then you go to the PCR test and rapid diagnostic test. And then you go to an ultrasound, then to the X-ray, then we need a CT scanner of 64 slides. So then we had to review all these, and then we sat down with the Atomic Energy Agency and we developed those specifications too. At the end, we came with a book that was launched in November last year. This is the book. This is all this, where do you need to use each of these technologies? Which are all the interventions, which are all the technical specifications. And the specifications are there because we need them to procure the equipment. We did exactly the same thing for personal protective equipment. And I just can tell you that these 2 publications are like live, they are interim guidance, and we keep updating them. And all those devices and their specifications got placed into this catalog, emergency supply catalog. And thanks to that, then countries can go there and select, I need this, I need this, I need this. And then WHO with other organizations was procuring those devices. Then a team of biomedical engineers also was doing the quality assurance to ensure that those supplies can reach the countries. At the same time, we have the innovative technologies because now everybody has new ideas. What can we do for COVID? So we have received about 300 innovative technologies. We are assessing them. We invite them to do a pitch presentation. We do a voting with an expert panel. We are selecting them. And we think that in the next 2 to 3 weeks, we will launch the first phase of the Compendium of Innovative Technologies for COVID, for low resource settings. And then as we are reviewing that, we have received many more. So now we will have maybe in 6 months, another book coming. But now we really acknowledge that for this revision, we are having expert panels of PPE, expert panels of respiratory experts, clinical care physicians from intensive care units, but we also have biomedical engineers from low and middle income countries, and then the Global Clinical Engineering Alliance, Euroscan, regulators to help us assess all these technologies. And we also have, these are the individual innovators, but we also, WHO is working with Grand Challenges Canada, for example, if Grand Challenges Canada has already selected 3 or 4 technologies, they say, okay, we give these to WHO now, just please check them. Are they useful or not? Do they comply or not with quality, safety, etc.? If yes, then let's put them in the countries immediately. 2 other very important initiatives also in WHO are the global research, so that all the information from research is put together and is shared. The sharing of data, the sharing of information, that's really what is allowing all of us in WHO and many institutions to be able to have better therapies, better diagnostics, and better vaccines to be available for all. But we have another thing. The government of Costa Rica actually made a statement, sent a letter to WHO and said, oh, we need like a technology access pool. We need something where we can put like blueprints and countries can develop or can do local production in their countries, that we can do technology transfer so that there is also a development. So we're also working with a special group that is on the CTAP and the technology access pool and also the CTAP and partnership and the UN Technology Bank, UNIDO, UNOPS, all of us again, trying to see what products can be produced locally, what industries are willing to give their blueprints so that others can develop it. So we are now developing, for example, for manufacturing of face masks, for example, of PPE. So in general, we can tell you that countries need more resources to support the urgent needs of medical devices for COVID and for essential health services too. Why? Because still we have people with diabetes, with cancer, with many other things. The supply is really limited. So we need to give also assure that the other diseases get treated. I just wanted to give you an idea of what do I do in a normal day. So I look into the issues about the COVID issues that are the PPE, the devices in the ICU, the oxygen, the CTAP. But the other hand, we have the non-COVID, the essential diagnostic list, the cardiac and the diabetes and the cancer and other things. So this is like a normal day. In the essential diagnostic list, we have the essential diagnostic that was launched just 2 weeks ago. And then we're trying to put together diagnostics that should be available in countries. As we have many books, so we are now moving into a software system, and we just launched it. It was proposed for March last year, but we just launched it a month ago. You can find it in the website. It's called the EEDL. Then we took all the priority medical devices and we said it is very difficult for people to go PDFs, download the PDF and everything. So as I told you, now this book, The Priority for COVID, got here in 2020 and 2021. We hope in 1 month to launch the cardiovascular, stroke and diabetes book. But we put everything together with the help of many biomedical engineers, extraordinary people that have been helping me day and night to put all the information together so that then with a click, you could find information about all the medical devices that are in these books. So the idea is that countries take these guidance, these books that are produced by WHO, they use it in their country, and then they said, okay, now we can define where in my healthcare settings can I put them. On other hands, what we have to do is disseminate continuously information. So we have the medical device newsletter that I'm in charge of every month and update what happens with the surveys, what new guidance, new consultations, anything that's happening. And we even have still the challenge of having a name for medical devices that will be used globally. So we are having sessions in the World Health Assembly to try to define what would be the best nomenclature. So that discussion is ongoing. So now I just bring you back to the first slide that I presented. Do you now remember our role? It's to design, evaluate, regulate, manage medical devices that will support local, regional, and global health in any of the settings that I'm presenting there. We need to listen to the needs. And this is not Uganda, this is Tanzania. But we need to listen to them. We need to adapt to the settings, and we need to empower the biomedical engineers locally, not to impose, but to empower. And that is something, and here I'm empowering women, biomedical engineers. And this picture, I just took it from our last meeting, and maybe one of them is still is now listening to this conversation, but the idea is working together. All the biomedical engineers from different parts of the world to solve local, regional, and global health problems. This was the 22nd of February, and we meet every Monday, and we are about 30, as you can see, from Botswana, from Benin, from Sierra Leone, from Canada, from the US, etc., etc., etc. So take home messages, and I know most of you are home, but then I said, well, anyway, I'll leave the take home. So number one, medical devices and IVDs are indispensable for outbreaks, well-being, and universal health coverage. Number two, biomedical engineers are indispensable to design, evaluate, manage, blah, 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 medical devices. And 5 issues to consider. Number one, consider local, first local, then regional, then global needs. Second, consider the healthcare setting environment, which are the limitations that that environment has. Third, listen to the voice of the final users. 4, share information and look for collaboration. And 5th, to focus on the last mile. Where is the last mile? That is where the healthcare worker and the patients are. So please always remember that a patient is at the end of all our activities. Doesn't matter where, doesn't matter how. And they and the health workers deserve our biomedical engineering knowledge, our passion, our transparency, our hard work, and our collaboration. Thank you very much.
Well, thank you very much, Adriana. That was fantastic. Horst, are you going to ask some of the questions?
Yeah, I guess I could read them. I think we need to read them for the folks who attend on YouTube later. So for the top of the list. And so this is a reminder to the folks who haven't had a chance to ask their questions yet. So the Q&A tab on the bottom of your screen has several questions already in it. So feel free to read them and see if they're yours and upvote them. And feel free to add your own questions if you haven't had a chance yet. So the first question comes from Professor Umut Gurkin at Case Western Reserve University. He says, hello, Adriana. It's great to see you. Could you please give an example of how the essential list of in vitro diagnostics is used in, for example, Africa? Are such lists published by the WHO, used by government agencies, regulatory bodies, caregivers, all of the above? Thank you.
Thank you very much, Umut. I do remember you. I do follow you in LinkedIn, and I know you've been achieving the sickle cell testing, and that is a major issue. And I really would like to say that sickle cell testing, and that's an example, it got listed in the essential in vitro diagnostic list, but for laboratories. And this year, just the launch that was done 3 weeks ago, it was for point of care technology for the communities. And that is because we saw the new developments, the new technologies that were just recently launched and available as a commercial and approved by regulatory agencies on sickle cell testing. That is an example. And the idea, what we're doing now is the guidance document for countries so that countries know what are the steps that they need to follow. We put a lot of social media and brochures. We just put them in the in vitro diagnostic website. This is new, absolutely new. And now we're doing the guidance documents so that then we can enforce that the governments, regulators, and so can put those tests in their national list for reimbursement, procurement, or so. So yes, absolutely, it's a yes. And we hope to increase availability of technologies like sickle cell and many others. So yes, Umut.
Okay, so thank you. So the next question I have is from Mackenzie Grubb. She says, great talk. From your experience, what are the best ways to partner with and empower local BMEs from other parts of the world? Thank you.
Sorry, to empower, can you repeat it because I don't see the
Sure. What are the best ways to partner with and empower local biomedical engineers from other parts of the world?
Okay, I think the best is really to work with the national societies in the countries and on the universities that are in the countries or the local people. So the main idea is to give them tools to make them worth it, so that it is not like imposing you have to do this and that, but really saying, what are your needs? How can I help you? What would you like to know from us, so that we can have other ways of doing things that might be different of what you're doing. And these are maybe better techniques or more information or anything, but it's really letting them request the help for the things that they need, and then support them and bring them support that they need, either in the university or through their professional societies. And they're super active, most of these societies in these countries. I hope this will help.
Excellent, great. The next question is from Chester Coe. Chester asks, Adriana, thank you for your excellent presentation. Pediatric device development is known to be challenged in the US and many countries due to a smaller population, less profit potential, et cetera. What strategies is the WHO using to overcome these challenges? That's for pediatric device development. Thank you.
And I think that is a very important question, because actually now we're trying to get a pediatrician into any of our experts' meetings. So to ensure that we don't lose sight of the pediatrician's pediatric needs. And we are actually ensuring, for example, the essential medicine list, it started at essential medicine, and now they have an annex for children. So we want to do many similar things for the in vitro diagnostics. And we're also doing that for the medical devices. Priority medical devices, they have a section specifically for children, and we're trying to adapt our medical devices and have a much more awareness that medical devices are needed for children. I hope that helps.
Excellent, thank you. Oops, I dropped my window. Let's see, from Fred Epstein. Hi, Adriana. Where do the financial resources come from to support biomedical engineering at the WHO? Thank you.
That's a difficult question. What I can tell you is that all countries provide funds to the UN system, and then member states provide money to WHO. But that is about only 20% of the funds that WHO has. The rest of the funds come from, let's say, specific donors, like the Gates Foundation or the USAID or Norway or Japan, or Germany. So some governments have the aid funds, and they are given to WHO. But some of these funds are given by those countries, maybe directly to the by those high income countries to low income countries directly. And so they give the money directly to the Ministry of Health or to the countries. To WHO, there's really very little money given. Actually, that is a major concern because we were lacking support to have more biomedical engineers in WHO, in the regional offices, in country office. So any ideas for funding support for increasing availability of biomedical engineers in WHO will be most than welcome. We're working, and now we will be getting a secondment from Japan in 2 months. So, and governments can also send secondments to WHO.
Excellent. That sounds like something we could also bring to the attention of the U.S. Biomedical Engineering Society.
And any way you can help us support for availability of more biomedical engineers globally in WHO regional and country office will be most than welcome.
Absolutely, thank you. So the next question comes from Ron LaPaul. He asks, it's clear that diagnostics, PPE, vaccines, et cetera, are today's pandemic bottleneck. As engineers, we like to think of tomorrow's bottleneck. What should we be thinking about for our next pandemic?
Well, actually, pandemics will come and continue to come. So we have had the Ebola, we had the MERS, we have the Zika. So we need to look into protection for infectious diseases. We need to look to support healthcare systems. So hospitals should be, for example, these issues about oxygen. There should be lack of oxygen in hospitals. There should not be lack of electricity in hospitals. So if at least we have the right diagnostics, then we can diagnose early a disease to prevent that there's other complications. In the case of outbreaks, we never know what can come. And our Director General, Dr. Tedros, and many others, he actually said it like maybe 2 years ago before everything happened. He said, we're not ready for a pandemic. If it's coming, we're not ready yet. So we need to have much more vigilance, much more diagnostics, much more control on infectious diseases in general. Now, as you all know, this week, Ebola restarted again in Republic of Congo. So yeah, we need to be protected and we need to be aware of that.
Excellent.
So hope that helps.
Good. So the next question comes from an anonymous attendee. He or she says, great talk. Thank you. What is your advice for student innovators to move their devices or inventions from the bench to the lab or benchtop or lab to the market? Okay.
First of all, we should, the students should not be just inventing something that comes like, well, I would like to do X or Y. Look into the needs. What is needed? So we have the compendium of innovative technologies in WHO, but what we really wanted to do, and we're working on that, is the compendium of needs. So what is needed in the world? So it is very good that you can go to a setting and say, what do you need to make your work easier or faster? My recommendation number one to all students is that they should spend some time in hospitals. It doesn't matter if they want to design equipment later or go to the industry or manufacturing or whatever. Be in hospital settings, be in a small hospital or in a small clinic. Go and see what they use, who uses it, who needs it. So if you start from the needs and it's needs-based, then you develop something that is needed. If you develop something that is needed, then you would ensure that there's no, that your product will not go to a prototype of, we call it a cemetery of prototypes. There are thousands of them. So the main idea is if you put time to do research and to do funds, what are the needs? So first asking the needs and then developing. And of course, there's now a lot of help and support to go from prototypes to the from the bench to the bed, no? To get the prototypes really out. But it's not easy. You have to go through all the regulatory process and then be able to be commercialized and know the market, etc. It's not a simple process, but now even in WHO, we are helping them much more than we used to do before. So even for helping to advance the prototypes.
Excellent.
Hope this helps.
Yep, thank you. From another anonymous attendee, she says, great talk. How do we tackle bureaucracies that hinder the work of BMEs, of biomedical engineers, in times of crisis? For example, I'm thinking about groups who were 3D printing urgently needed ventilator replacement parts and then threatened with lawsuits. Similarly, I recently read about companies who made hand sanitizer that are now subject to penalties from the FDA. How do we tackle those bureaucracies?
Well, some are bureaucracies, others are really issues about safety and quality, no? So can we ensure that whatever we're doing with the 3D printing, and actually I would like to say about the 3D printing and homemade, so it could be 3D printing or any other, if you download the blueprint and then you develop something like a ventilator, who would ensure that that ventilator has good quality, that it was correctly manufactured? So there, the same things happen with a lot of medical software. So how can we ensure that there will be better guidance for those that are developing those, and that we can have a path to approval those? In the regulatory agencies, now there's even a new track that's called innovation, and that innovation is for like a do it yourself. So it is something that was, there's a name for that, but I forgot it. But it is like where you don't have really an industry developing it, but it is more something that you develop locally. And then we have to have also a regulatory approval pathway for that. Hope that helps.
Good, thank you. So a question from Julio Aleman. He asks, among the many lists and databases presented, is there a way to narrow down priorities by country?
Yes, actually the main idea, and that's what we want to do, and we're developing that now, it is we have the books, then we're going to the database. And then the idea is that those databases will serve as a clearinghouse. So the next step that we are developing right now in WHO is what is called the UHC compendium. That is the Universal Health Coverage Compendium. That compendium will list all the package of benefits that you have. So it is all the healthcare interventions. And the idea is that countries can use it to say, okay, what do I need? Do I need to take neonatal care is a high burden? Do we have a high burden of disease of neonatal mortality? Then what are the things that are needed? Or is it cancer care? Or is it, but all the time countries have to prioritize. It is not an easy target, and it depends on the bag of money they have, on the human resources that they have, on the financial resources, the technological resources, so that they can make this prioritization. But it's always, they will need to decide how to prioritize. Both in the priority medical devices and the essential in vitro diagnostics, we are developing now a tool to help them prioritize. So we hope that will help countries or decision makers.
Good, thank you. So a question got voted up right past where I was looking. This one's from Professor Dominique Durand. He asks, can you comment on the gap between clinical engineering and biomedical engineering? There seem to be similarities and differences, particularly in different countries.
Yes, and good to see you, Professor Durand. Well, not to see you, but to listen to your question. Number one, in most of the countries, and that is why we named the book Biomedical Engineering, healthcare workforce for medical devices. And inside the book, we said in some countries they call them medical engineering, in others bioengineering, in others, etc. So they have different exceptions for the same function. The biomedical engineering is working more on the research side, but in many countries, the biomedical engineering, it's the only bachelor's program, master's program, or postgraduate program that is recognized in the country. They don't have a clinical engineering master's or bachelor's program. So that's why we keep naming it biomedical engineering. Nevertheless, there is now organizations of clinical engineers, like clinical engineering, Global Clinical Engineering Alliance and the CED, etc., that are really trying to recognize the labor of the biomedical engineers that work in healthcare, like hospitals and so, to recognize the name clinical engineering. So in some countries, it is more accepted than others. And the main idea is that the clinical engineer is really in the clinical setting, and the biomedical engineer can always stay in the research part or in the lab or manufacturing, design, research and development. So I hope.
Good answer. Thank you.
Well,
The next question comes from Ricardo Sanchez. He asks, he says, fantastic talk. Other than the academic achievements, what can we as students do to improve our chances to progress in our career path?
What can students do to improve our chances to progress? I think number one is don't give up. So it would sound silly, but it is not. If you have your dream and you want to pursue it, just keep on going. Life is not easy. I can tell to all of you that the first job I applied for, they rejected me because I was a woman. No, so you just have to keep trying, and if you really want to achieve it, you will make it happen. There's also difficult times because of corruption, procurement, things like that. So just don't let that stop you. If you have your goals well set, be ethical, be don't let things down. Just think of your dream and keep on going. But another thing is, it is like in everywhere, in universities, in the ministry, in the industry, there are always, we can call them bureaucracies, but just try not to listen very much to that. Just listen to what you have in your passion and say, I want to have a better medical device to solve this specific problem for this specific person. And then the others don't, it kind of bypass that, no? You know they're there, but just continue your career path. And look for others and share your information. Now it's so much easier with all the social tools that we have now, that it will be much easier now.
Excellent advice. Difficult advice, but excellent advice. I think maybe we're running low on time, so maybe the last question. This comes from Paula Painetti. She asks, she says, great talk. Should biomedical engineers get additional training in public health in order to effectively advocate for the needs of patients with different governance bodies? Yeah,
that's a great question, actually, because two suggestions there. Biomedical engineers it would be really good to know not only about physiology and biomechanics and so, but also learn how to manage. So management skills and also public health skills. So if they know that and they spend some time like an internship in a hospital and then knowing exactly what are the global health or local or regional health inequities, then they will be able to understand better. And exactly the reverse for the healthcare workforce. So we want the nurses, doctors, and all the healthcare workforce on the clinical side, that they would have more lessons about biomedical engineering or medical technologies, because they are the users of the technology, and we're looking forward to change or adapt the curricula for both areas so that it will be much more complementary and not totally separate. So that's the proposal.
Excellent, thank you. So we're right at 5 o'clock. I appreciate a fantastic talk. I think I learned a lot. I always learn a lot when I hear you talk. I feel empowered. I feel motivated to get out there and do more. I hope the audience for our Open BME seminar series enjoyed the talk as well. The talk is now posted on the Open BME site, and that will also link to a YouTube if you want to see it again, if you want to point your friends to it, etc. So with that, let's thank Adriana Velazquez for her wonderful talk.
Thank you very, very much. And I thank you for your time. And I just want to say that from the universities that are here, of course, I'm an alumni from CASE, but I also have collaborators with me from Michigan, and my son studied in Northwestern. So, and we have been working with Rice University too. So I'm really happy to be with all of you. Thank you. And
thank you.
Be safe, please. Stay safe.
Extra
Thank you.
thanks, Adriana. We're all worried about it being 5 o'clock. It's 11 o'clock where you are. So you worked a late shift. Thank you very much.
Thank you very much. Take care.